Good afternoon, everyone, and welcome. I'd like to acknowledge the local custodians of the land in which we're meeting on today and honour elders past, present and emerging. I'm Melissa Wilkinson from the Hunter New England Central Coast Primary Health Network. Welcome, everybody. Thank you for being with us today. We've got a large number that are coming online and registered, so it's fantastic. We've hit the spot with this topic, so it's very exciting and looking forward to it. Just some housekeeping. I strongly encourage you to please use the questions box, get that interaction. If we don't get through all the questions today, they'll be forwarded to the panelists and we'll get back to you afterwards. We are being recorded and a copy of this will be available in the Education Library along with some resources as well, so you can refer to them after the event. And also there will be the survey at the end of the session. So it only takes a couple of minutes and I strongly encourage you to please complete that, because that's where we get our data and base our further education events upon that. So that's really important, and we thank you for always being so engaged and completing that for us. It gives me great pleasure. Now I'm going to hand over to Hannah Jenkins, the Digital Health Officer with the PHN. Thank you, Hannah.
Thank you, Mel. Good afternoon, everyone. So today we're going to follow the journey of a BPAC SeNT eReferral. Ruth, if you wanted to just change that slide. Perfect. So my name is Hannah Jenkins and I am a Digital Health Officer at the Primary Health Network. I'm joined by Peter Mullen, who is another Digital Health Officer, as well as Marilyn Dixon, who is the Manager of the Digital Health team here at the PHN. We're also joined by Ruth Tanagazi, who is the Clinical Coordinator at the Contact Centre for Hunter New England Health, Local Health District. So today's Mastermind will follow a SeNT eReferral as it travels from the general practice to the LHD and learn more about what happens to referrals once they arrive at the LHD. Peter will also give an overview of the private SeNT eReferrals, and we are hoping to have some time for questions at the end. However, if we don't get to that, there will be an email address at the end of the presentation that you can use to contact the digital health team at the PHN. Thanks, Ruth. So today we will be following John. John is a retired 70-year-old man with a 5-year history of type 2 diabetes. This is all fictional. John has arrived at the general practice for a chronic disease management plan. He is presenting with recent weight gain, suboptimal diabetes control, and foot pain. So John has just recently started seeing Dr. Jones at Main Street Surgery, and today we will follow his referrals as they travel through the public and private systems. Thanks, Ruth. So John initially sees Nadine, who is the nurse, and she begins the chronic disease management plan. Nadine identifies that John would benefit from a referral to a podiatrist and exercise physiologist as part of his team care arrangement. Nadine opens the SeNT eReferral program and identifies a private podiatrist and exercise physiologist that John could see. So she goes through and fills out the eReferral with all the information gathered during the chronic disease management appointment. As Nadine is a nurse, she's not able to submit that referral. So what she does is parks the referral ready for Dr. Jones to review them when John goes in to see him next. So with the latest enhancements that have just been released, nurses can access the system to begin referrals and park them. At this time, only GPs and nurse practitioners are able to submit referrals. Thank you, Ruth. Thanks. So next, John goes in to see Dr. Jones, who reviews the 2 referrals that Nadine has parked. He's really happy with those, so resumes them and sends them off to the private allied health providers. After reviewing health pathways, Dr. Jones decides that John would benefit from seeing an endocrinologist at the local hospital. He's really impressed with the level of detail that's been included in the referrals that Nadine has completed, so he copies those and changes the specialty condition section to send to the endocrinologist. By copying the referral, the GP has saved time writing out the referral letter section, which can be the most time-consuming part. So John needs some updated pathology, so Dr. Jones sends him off with a pathology form. Dr. Jones parks the referral awaiting the test results. The SeNT referrals are saved into the medical software, so no admin time is required at the end of that appointment, and Dr. Jones will receive a notification into his best practice or medical director inbox once that endocrinology referral is actually sent off and received by H&E Health. Thank you, thanks. So a week later, Susan, the practice manager, is conducting her regular review of the parked referrals in the SeNT system to make sure nothing is being left behind. So she uses the practice view page to view all the eReferrals that are parked and yet to be sent. She notices the endocrinology referral for John is still parked, so asks Dr. Jones whether or not that can be sent off. The pathology has come back, so Dr. Jones adds that to the referral and sends it off to H&E Health. The recent enhancements means that the whole practice can be involved with the management of SeNT eReferrals. If you would like a demonstration of the features that I've mentioned today, they've just been released, please let us know via the email address that will be at the back of this presentation. I will now pass it over to Ruth, who again is the clinical coordinator for the contact centre at the John Hunter Hospital Outpatient Services, and she'll be taking you through the Hunter New England Health referral management process. Thank you so much, Ruth.
Thanks, Hannah, and thank you all for giving me the opportunity to present to you today. I guess it'll be interesting. I think the PHN have done a lot of work with SeNT eReferral leading up to this, but sometimes I think that this might be an opportunity for you all to see what actually happens at where we receive those referrals, and it may have been a perspective that you may not have been fully aware of, so I'm happy to share that with you so that you can see what happens at the LHD end. I might just mention firstly that I represent the outpatient services in my area, and it is only a small part of the overall outpatient services that are provided at John Hunter Hospital and beyond. And that will become more obvious when I present my further slides. So first of all, I guess from a GP perspective or a referrer perspective, is there only one centralised outpatient service for all of the John Hunter referrals? So the answer to that is no, there's not one outpatient centralised service. So that actually poses a question and becomes quite problematic at times for referrers in knowing where to send their referral to, and is it reaching the right specialty and the right location. There's multiple entry points and there's multiple outpatient services that exist. As I mentioned in my earlier slide, I belong to one outpatient service, but maternity and gynecology run their own management and processing of referrals, as does Children's Hospital. There's a number of medical and interventional services and specialties and surgical specialties that actually manage their own referrals amid a myriad of other specialties. So I'm just representing today the 17 specialties that our service looks after, but I guess for you, trying to know where to send those referrals and who's managing and processing which referrals, and are they getting to the right consultant in the right time frame, and also to the right specialty, etc., for triage and clinical review, can be quite challenging. So if I'm talking about the outpatient service that I work for, and the 17 specialties, we would average around 1,200 referrals or documents coming into our service in the referral portal each week. So this is an average over the last 20 weeks, and you'll probably notice that there's a few dips. That's traditionally around the Christmas holiday period, and we did have similar dips back in, say, May last year when COVID hit. Which probably replicated what was happening in GP referral practices. So we're back up to some really high numbers recently, and that's a lot of referrals to actually process per day. It's roughly around 300, 1,200 a week, or up to 63,000 a year, just for the service that I work in. Plus, overall, we've got all those other services that I alluded to before. So How does your practice currently send referrals? Is it by fax? Is it by SeNT? And more recently, and unfortunately, we've been receiving a number of referrals via email. This is considered to be not a secure pathway for sending referrals, and it's something that we certainly don't encourage. And I will be able to explain a little bit more when you see what happens with the pathways for the referrals coming in with these different modalities. So how does your practice identify who and where to send a referral? And as I said, it does depend on how you are sending your referrals and what modality. But given what I've said before, it does mean that your practice may need to maintain a service directory. It would need to know whether it's for private rooms or public rooms, and a lot of our consultants work in both. Who are the current doctors working in that specialty? And some doctors actually work in more than one specialty. Do you have the correct details for the current doctors, their specialties, and where they actually work and where their referrals should go? There are a lot of varied processes and clinical template forms for sending referrals that you may not be aware of, that are currently used and required for providing accurate information so that the triager can actually fully look at that referral with the information that's needed rather than sending it back for further information. And unfortunately, we still have a lot of practices sending referrals for doctors who have retired or are not working at the hospital any longer, and or have deceased, which is really unfortunate. We do have two useful resources that can assist you in keeping you up to date and the practice up to date. That especially with SeNT, you don't need to maintain a service directory. We've done that for you. So between the LHD and the PHM, we are constantly keeping them up to date so that these platforms will have the most current information that we actually have at hand about where doctors work, what they're doing, and their contact details. So how and where is your referral received? Again, it depends on the modality that you use to send it. And a lot of practices will actually get their admin team to ring the contact centre and ask whether the referral's been received. Or we also get a lot of patients calling the very next day to see if their referral has been received. The expectations of this is quite challenging, especially until the event of SeNT referrals, because we do not know if the referral's been received by name of a patient without knowing the date and time that you sent the fax, and this will become more evident in a moment. So the platform that we receive the referrals is called the Referral Information Management System, or RIMS. And what happens here is all those referrals, those 300 plus a day, come into this portal. So this is a screenshot of the incoming page. This here is a faxed referral. So it comes in as a document number, it has no patient name, it has no specialty, and it has no urgency. So if any of your team or the patient calls and we haven't processed that day yet, the only way we can find a referral is to open every single document, hopefully have a time frame that might help us to find that document. With the call queues that we have, sometimes are extremely long, and patients are quite disappointed to find out that we cannot find their referral, and nor do we have the time when there could be over 100 people in the queue to go and look for that referral. It takes us longer to get it through the process and get a name onto it. Unlike SeNT, which if SeNT comes in, we can identify it's a referral by its labelling in the documents section. It has the patient's name on it. I've de-identified these for the purpose of the presentation. It also gives us the specialty and the urgency that's been assigned. So as one would expect, if there are very urgent or urgent referrals, then that flags us to those, and we're able to actually look at those more quickly to get them through the system. So it actually is much more advantageous for the patient, your practice, and to getting these referrals to triage much more efficiently by being able to identify that straight away without opening all these documents. So how and where is your referral received? As we said, it depends on how you send the referral. I haven't mentioned email yet, and that's for some very obvious reasons. I already spoke around the fact that it's not considered to be a secure way to send referrals. But when you send an email, whose email address is it going to? Is it actually getting to the intended service or department that you want it to go to? A lot of the emails that we receive are in an email that is not solely designated for referrals. It's an email box that gets everything sent to us, no matter whether it's a referral, a staff member's sick leave, or something else. And your referral could be mixed up in all of those emails. It's not the intended place for the referral to be received, and it's not given its merit and dealt with as quickly as we would like to, because we can't identify that it's a referral. It requires then manual identification as a referral, and then it takes our admin team multiple steps to manipulate that document and have it uploaded into the intended portal for referrals, which all causes delay. They may be lost to the system. They may need to be redirected to a different email address within the facility or a different fax, so it reaches the correct specialty. And then that delays processing for triage. So it's definitely not the way to go in its current format, aside of the it not being a secure messaging platform. So in summary, let's review. We've got two methods of modality and one that's been creeping in of late for a number of different reasons and challenges that exist out in referral land. Security, SeNT by far is considered the most secure for patient information, with fax following and email certainly not considered secure. The patient can be readily identified in SeNT, but it cannot be in the other modalities, same as the urgency and the specialty being readily identifiable. And I was able to show you that in the screen before. The other thing that I haven't really focused on is it what modality decreased the request for additional information and the ping pong that exists between referrer and LHD. And that, again, SeNT comes through positively there because it's got a templated, somewhat required criteria for the referral. So we're not needing to ping pong back to you. It saves triage time, and it also saves referrer time in not having to readdress that the outstanding request for information. You can actually add information in SeNT to the original SeNT referral by updating. It comes in a standardized format, which is good for everyone. It's legible. You don't need to maintain a service directory at the GP level with SeNT, and I spoke about that. We get an immediate delivery to the intended referral system so that it can be processed and triaged. Definitely not what happens with an emailed referral at all. And in all of that, some of these advantages can actually improve the resources or better utilise your admin resources, efficiency and stationary costs. And most importantly of all, it can reduce the clinical risk due to delay and not reaching the intended recipient of the referral. So common goals of referral processing, and I attended a Ministry of Health, New South Wales Ministry of Health seminar this morning about outpatient referral criteria. And some of that and the eReferral is really around reaching the intended recipient on first attempt, clinical review as soon as possible, To minimise the request to provide information or further information and await further clinical triage or the ping pong. And fourthly, that the notification of the outcome of the referral triage is sent as immediately as it can be to the patient and the referrer. So the patient and the referrer know whether the patient is getting an appointment or whether they need to be put on a wait list. So I hope I've been able to share that journey that many of you may not have seen before or been aware of. And I ask the question now, how will your practice send referrals in the future? Will it be by fax? Will it be by SeNT? And hopefully it won't be by email. Thank you. And now, sorry, Peter, I'm going to hand over to Peter Mullins for the last slide of the day, the last couple of slides. Thanks, Peter.
Thanks, Ruth. So, yeah, I just wanted to probably quickly run through private referrals. From a technical perspective, they work pretty much exactly the same as those going into the public service. But there's a few little nuances with private referrals, so that's why I thought I'd just highlight the differences. With our private referrals, our private specialists and allied health providers, we only list those in SeNT by consent, whereas all of the public services are already pre-listed in there. As Ruth mentioned, they maintain their own directory. If your doctors do have providers that they refer to regularly, we can contact them. So if you let us know through the eReferral@thepahn.com.au email that you'd like us to contact them, we can do that. Now, one of the big differences is, unlike the public referrals, you don't get that receipt back into your doctor's inbox when a referral is received. The LHD sends you back a received receipt. We don't do that for private referrals. We are working on that, but at the moment, the only notification that the GP or the nurse gets is when they submit the referral. It flashes up with a dialog box to confirm that the referral has been submitted. Whereas the SeNT referrals in the public system, again, go to RIMS. Private referrals are delivered into a secure web portal. So that web portal is hosted here in Australia, so there's no information travelling overseas or anything like that. All the information is secured here in Australia. What happens is, as soon as the referral goes through, the BPAC system is running what we call a dead letter system. We often get, I see instances where referrals are, practice will ring the receiving practice, say, have you received the referral? Or they'll contact to check that, because they haven't got that, because if they haven't received that received receipt, they then think the referral hasn't gone through. But running in the background is what we call a dead letter monitoring service that BPAC run. And that picks up anything that isn't delivered in the first instance, requeues it and resends it, and it monitors that. So if there's ever any problem with the delivery, that's picked up and dealt with. And just to put some context around that, in over 90,000 referrals that have been submitted through the BPAC, the SeNT referral system to date, we've actually only had 3 that were picked up as dead letters. So, the system has a lot of integrity and a lot of fail-safes to back it up. So it's very, very secure and very, very, good at delivering what it's supposed to do. Receiving practices, the allied health or the specialist practice, they receive an email. So that's the referral is actually delivered to them into their portal almost immediately. They receive an email at the same time telling them they've got a referral. In that email, it doesn't contain any patient information, any referral information, doesn't tell them anything. It's a standard email, and all it does is have a hyperlink that takes them off to the BPAC Referral Manager website, which is where they manage and maintain their referrals. Usually most of them will then take them from there, print them as a soft copy or as a PDF and upload them into their own PMS. So what I'd say to you is, look, let your clinicians know. I do see a number of referrals where they'll be duplicated very quickly in the system, and often I think that's because the GPs aren't used to seeing that red receipt for a private referral, and so they'll think it hasn't gone through, they send it again, or they'll come out and they'll ask the admin to actually fax it off. So save yourself some time, save the receiving service some time, and just assure the GPs and doctors that it is going through. The other thing is that all the private referrals are monitored by the PHN team to make sure they're all accessed in a timely manner. So we have an overview of the system for private referrals. We can see, it's a bit like an email inbox, when they're opened, when they're not opened. And we have protocols that we follow up with the receiving service. So an urgent referral, we'll contact that service within about 24 to 48 hours if it remains unopened, and 48 to 72 hours for a non-urgent referral. So you can be assured that that the services are followed up, that referrals are followed up, and they're being actioned within a reasonable amount of time. We do have occasions where you'll ring the receiving practice and they'll say we haven't received the referral. Often that's because they haven't opened the referral inbox in their referral manager to see that, so they don't actually realise that it's there. But as I said, if you can rest assured that if your doctor has submitted it, it will get through. That's probably pretty much it for me. Oh, the other thing we do is also provide technical support to all of those private providers. So, if they're having any problems accessing referrals, they get that support as well. That's it for me. So I might throw back to the team for questions. If there's any questions that have come through, Mel.
Yes, we've just got the one, so you must have been very thorough in covering everything so far. But if anyone has any more questions, could you please pop those into the questions box, because we'll address them at this time. Subscription-wise, the cost for GP practices, is there a cost, and is it a subscription to use SeNT?
I can answer that one. It's for the 7 years that the SeNT program has been running. The PHN and LHD, it's a jointly funded program, and it's completely funded for general practice. So we also provide, and part of that funding includes IT support when there are issues with access to SeNT or GPs and clinicians getting access to SeNT. So yes, it's fully funded. There's no cost to the practice. The only cost I would say is if you choose to involve your own IT provider and they pass on their costs to you associated with that. So, but just know that the IT support is available also.
Great, thank you so much. I've got a couple of big thank yous in the chat box and question box as well. If anyone has any questions, I'll just give a minute or two there while I just remind you to please complete the evaluation at the end, and that we are being recorded today, and some resources and a copy of the presentation will be available in the Education Library. So that looks like that's it. Thank you all so much for being here. We do appreciate your time, and it was a great topic. So I'm going to end it all. Have a lovely afternoon, everybody. Thank you.
Thank you, everyone. Thank you.
Yeah, right.
Thank you.
Yeah.